two cardinal indications which those working in the infertility workup do care for. The first one is in IVF, and the second one is in unexplained infertility. And now the question is, do I need to do screening for ovarian reserve in all women seeking fertility? This is what are we going to try to solve in this talk. Now, concerning the first indication in IVF, according to Prof and Fritz in 2005, ovarian reserve is recommended for all women planning to do IVF. And the aim is, first, to identify women likely to respond poorly, or those who are more likely to have their treatment cycle cancelled. And secondly, to identify women prone to ovarian hyperstimulation, which is very well known to be associated with significant morbidity and mortality. The second indication is unexplained infertility. Any case of unexplained infertility, even those less than 30 years, because significant proportion of those have abnormal ovarian reserve. And recently, it has been issued the issue of premature ovarian failure, which is associated with an increased risk of being a carrier for pre-mutation on the fragile X mental retardation 1 gene. And let me explain this please for you. Look here, here is the X chromosome, and here is the fragile area, usually is situated on the lowermost part of the long arm of the X chromosome. And under normal circumstances, we have sequence of trinucleotides. These trinucleotides also are the cytosine, guanine, guanine. And this sequence under normal condition are between 7 and 50 or 52 trinucleotides repeats. But the condition is not usually constant. Sometimes under normal circumstances, this number is repeated more than normal. For example, in normal condition, we have 7 to 52 nucleotide repeats. But we have a gray zone in which these repeats are increased from 52 to 200. And this is a gray zone in which the patient is now became carrier or becomes carrier for the FMR1 gene. Those patients suffer anxiety, depression, and highly resistant type of PCO, and they are more subjected to premature ovarian failure. Now, when these repeats increase more than 200 cytosine, guanine, guanine trinucleotides, we have the fragile X syndrome. This is the form of fragile X syndrome, or the frank picture of fragile X syndrome, in which we have mental retardation, anxiety, ataxia, tremors, and look to these characteristic faces in which the patient usually have prominent ears, elongated faces, and usually the eyes are separated widely from each other, and we call this hyperterrorism. Now, the issue is that we can find an increased frequency of occult fragile X-associated primary ovarian insufficiency in infertile women with evidence of impaired ovarian function. And hence, when you find a patient which is highly resistant with multiple failure of the IVF, you have to think about the possibility of fragile X syndrome, and you have to test for the FMR1 gene in those patients. If we are able to identify those women less than 30 years with diminished ovarian reserve who are at risk of premature ovarian failure, we might potentially pick up the occult cases of fragile X syndrome. And this test is simple. We can do it by the increased methylation can be discovered by the polymerase chain reaction or by the sudden block technique. Now, this paper has been published in 2010, and this paper issues the importance of an associated autoimmune disorder with those patients with FMR1 gene, which means that if you have repeated failures in IVF in a patient who have nothing but resistant PCO, you have to think about doing this test for the patient. And for the magnitude of the importance of this test, this is an example in Wales. Look here, all Wales Molecular Genetic Laboratory has put in the prices of the PCR for FMR1 and Southern blot for the FMR1 gene, and even they are putting the price valid until March 2013. They are trying to pick up those cases in spite of paying a lot of money of repeated failure of those cases. We can pick up those patients with repeat FMR1 gene. Now, the third indication after the first one, which was in all IVF, and the second one in unexplained infertility. Now, the third indication is, do we do the ovarian reserve screening in all women seeking infertility? And the answer is that some investigators recommend ovarian reserve screening by a simple reproducible test such as the antral follicle count as a core part of the initial fertility workup in all women seeking fertility. And the aim is, firstly, to know how many eggs left in her basket. And secondly, to heighten the awareness that their fertile years might be more limited than they anticipated. And thirdly, young women need to be more aggressive in their infertility treatment. Which means that لو أنا عيانة جات لي في أول مرة والعيانة دي صغيرة في السن وجاية تقول لي أنا عايزة أجل، أنا مش عايزة أجيب عيال دلوقتي وهنستمتع بحياتنا 3-4 سنين قبل نجيب عيال، لا. And by a simple test in my own clinic, just by, as you will see now, by doing such a test in my own clinic by my 2 conventional 2D ultrasound, I can answer these 3 questions. I can tell her, please, you don't have a lot of eggs left in your basket. You should try and attempt at any time, at the nearer one time to start fertility workup and getting pregnancy. Now, about the marker of ovarian reserve, we have ultrasound markers, and I'm not going to lose time apart from talking about the antral follicle count because it is the most important. And along the endocrine markers, we have FSH, estradiol, inulin, anti-malarial hormone, clomiphene, citrate challenge test, and exogenous FSH reserve test. We are not going to lose time because the anti-malarial hormone has proved to be the strongest. We are going to put the strongest in front of the strongest of each type of tests. Now, we start by the ultrasound markers, and we are going to focus on the antral follicle count, and it is defined as the number of small follicles measuring between 2 and 10 millimeters, as you see here in loose ovaries. This number reflects the relative number of microscopic primordial follicles remaining in the ovary, and each primordial follicle contains an immature egg that can potentially develop in the future, and therefore, the number of antral follicles is directly proportional to the remaining ovarian reserve. So the test is simple. Just we count the number of these follicles in both ovaries. And I stress upon this fact, in both ovaries, starting from the 5th day post-menstrual. And we have multiple methods. We have, this is a conventional 2D method, and this is a rendered inversion mode by the 3D, and this is a multi-planar 3D method, and this is a sono AVS automatic volume calculation. الأجهزة الحديثة بتقدر تلون زي ما احنا شايفين الفوليكلز عشان نعدها at a much easier way. So these are the 4 modalities, and you can do this modality at your own clinic. You don't need to send the case to a higher and more expensive, sophisticated centers. Now, what about the antral follicle count and ovarian reserve? Look to this paper. This paper is very strong because it's a meta-analysis. And we know that the meta-analysis and systematic review of all randomized controlled trials give the strongest level of evidence in clinical practice, which is level 1 evidence, and also give the strongest level of recommendation in clinical practice, which is level A recommendation. And this is simply the accuracy of multivariate hormonal model predicting the ovarian reserve. They put multivariate hormonal model on one side, and they put the antral follicle count on the other side. And the multivariate model consists of some type of inhibin B, FSH, even they have used the anti-malarial hormone, and please, sorry. And they have put all these hormonal model on one side, on the other side they have put the antral follicle count. Now, to summarize, this is the ROC curve. This is even a summary ROC curve. And they have used about, or they have summarized about